Good morning, good morning, good morning, dear friends. Welcome to the second Congress on Cervical Cancer Elimination in Africa. This is one of the projects that we are really so proud. One of the most popular Zoom meetings of ESGO. We did the first time last year. We get a lot of positive feedbacks, and today we decided to make the second one. Yes, the topic is cervical cancer elimination, and our focus is Africa plus low middle income countries. Dear friends, I want to congratulate the whole ESGO team and our experts, Susanna, and the whole prevention committee. By now, we have more than 1,200 registered people. Do not panic. You can all go back today afterwards and see the webinar, some of the sessions later on, and get some slides. And secondly, we are more than 50 countries, a lot of African countries, particularly Egypt, Middle East countries, Ghana, Rwanda, South Africa, Congo, a lot of countries today. Senegal is with us. And our focus is just you, the low middle income countries. The best European experts, the HPV vaccination, screening, and cervical cancer treatment, are again today with us. Please do not hesitate to ask any of your questions from the messages section, Q&A sections to us. I really want this webinar to be more interactive with your active participation. Plus, don't forget, we have a lot of projects and we can do together for Africa. These experts are coming for you. If you have any good projects that we can realize with ESGO, again, please send them to me and to Susanna and to ESGO Prevention Committee. So we will do our best for you, definitely. And of course, one of the most important issue is that the cervical cancer, we ESGO has just produced a treatment guidelines, but additionally, I want to emphasize that this is not sufficient. We need to produce resource stratified prevention guidelines. So what is the best policy for vaccination? What's the best policy for screening? We can discuss per each country, different infrastructure, different funding situations. But at the end, the target is always the same, to eliminate the cervical cancer in Africa and then, of course, the whole world. Therefore, after this Congress, it's our pleasure to welcome you and together produce with our new president-elect, Jalid Sehouli, resource stratified prevention guidelines with limited resources, what we can do and how we can improve. Okay, so dear friends, in addition, something new in this conference is that we realize that in Africa there are different types of languages, and some talk English, some talk French, some talk Arabic, some even talk other languages. Also, by today, we have Central Asian countries which dominantly use Russian languages. And then, of course, this is how you can make today we have more than 50 languages. If you have difficulty to follow the webinar in English, please use this multi-language broadcast. We just now, our technical team has sent you a link. Please enter this link, and this is what you can do. You will just register, and you will select your languages, which can be Arabic, Russian, Turkish, Spanish, French, English, whatever you like. All the day, you can easily follow this webinar from this particular application. in your own mother tongue languages. So before giving my microphone to Jalid Sehouli, the president-elect of ESGO and the moderator of the first session, I just want to thank once again the ESGO team, the ESGO office, and of course, Susanna Santamaria. Susanna, would you like to say a few words now by the entry? Did I forget anything?
Absolutely not. I would like to take the opportunity to thank everyone who is joining the webinar as attendees and mainly to all the speakers. Thank you.
Thank you so much, Susanna. And now the microphone is yours, Jalid. Let's move from Ankara, Turkey to Berlin, Germany. Jalid.
Yes. So good morning from Berlin. And again, it's unbelievable success of this outstanding initiative. And thank you personally, Murat, for your engagement since many, many years, because we are socialized to treat, but prevention, primary, secondary, tertiary prevention, I think is really one of the goal. And cervical cancer is a signature disease for women health at all. And that's the reason why I think we can learn from each other. And the announcement of the WHO in 2020 to eliminate cervical cancer is really a milestone in medicine at all. And to bring every young girl to vaccination, to bring every woman to screening, to bring every woman to an adequate treatment. This is a goal. And I think this is even our responsibility as the European Society of Gynecology to bring prevention, treatment, and cancer care in one holistic approach. And I'm very proud, and thanks to you, Susanna, to bring this network in a so dynamic fashion. And we will start now from an overview, and then we go deep by deep to best examples all over the world. And please interact with us because we want to learn from you, because you even experienced, but we have to bring the experience together and to adapt our ideas and guidelines. So thank you very much again, Murat, for your sustainable engagement. It's even your personal success, and it's a success for the women health issue. So let's start, because it's a busy schedule today. Andreas Ullrich, we are very proud to have you at ESGO. You've been so experienced and worked so many years with the ESGO and now with the ESGO to bring even this issue in a political way. And thank you very much. Let's start, Andreas, and give us
Thank you very
an
much,
overview.
Jalid. It's an honor to be on stage virtually. Thank you all for joining, and it's really a pleasure and honor for me to present as first presenter something which we can call an immense success story, which started with a small meeting at the WHO in 2006, 8, when we started to think about HPV vaccination as a global tool. And from this invention, from this idea that cervical cancer is preventable by a vaccine, by an innovation, and by other interventions along the life course of women, we are united now, not only as a WHO, as in my former life was at WHO as the head of cancer, and now I'm with Jalid at the Charité University Hospital, working on global women health. So this is a fantastic journal, and I would like to ask you to join me in this journey. And I try to move my slide now. My slide is not moving. Up. Yes. Now, my journey in these 15 minutes is that I will give you an overview about how we are aware of the burden, how we can get to data, and what is the current status. I then go to my own story about WHO as a global movement to elimination, and we'll talk a little bit about the current status of vaccination and screening in sub-Saharan Africa, and how we as a clinical institute also have the opportunity, using opportunities to global outreach. And then we come to take home messages. This is a picture you might know from many, many other presentations, but what I would like to give you a little bit of flavor how to get to this data. This is the cancer mortality, cervical cancer mortality. First of all, don't see it as cervical cancer in isolation. When we see mortality per 100,000, which goes in cervical cancer in some parts of sub-Saharan Africa up to 60 per 100,000, we come in the dimension of communicable diseases, with malaria having 56 per 100,000 deaths among women, and tuberculosis 91. So we are in a public health challenge. That's the reason why we as the WHO and now we as the community of gynae-oncologists have taken this not only as a clinical subject, but as a public health and global health challenge. These data comes from International Agency of Research on Cancer initiative to create national population-based cancer registers. This is extremely important to get precise data. And many of you might not know that this work is continuing and is emerging in sub-Saharan Africa. A recent report from IAC, from International Agency of Research on Cancer in Lyon, says that the capacity of countries in the African region to develop a national or subnational population-based cancer register is increasing. So the data which we can build upon, national strategies, is solidifying, is getting more and more precise over the years, thanks to the network of and the global initiative of cancer registration. So we have high-quality cancer registries in Uganda, Zambia, and Malawi. And some are in process to develop national standard cancer registries. So the data about cervical cancer incidence, mortality, and trends is getting more and more precise. Now we go over to the incidence, because incidence is what is the global target of the WHO strategies. This inequality between low incidence in high-income countries, as you see with blue in the clear part in Europe and some Middle East countries, compared to dark blue. Our target of the elimination strategy is 4 new cases per year per 100,000. And this is the target the whole world would like to achieve by implementing evidence-based strategies on prevention, early detection, and treatment. This is where we want to go and where we are now. So we need the gap, we see the gap, and this is what we need to do, is to apply the strategy, global strategy, regional strategy, and national strategies under the following guiding principles. It is extremely important that we have national stewardship, that the strategy is not top down from Geneva, from ESGO, but it is absorbed by the national authorities and their national stakeholders like NGOs, private sector, foundations. So the government stewardship together with other stakeholders is an extremely important element of success. Then every decision has to be taken based on evidence-based intervention, what works in screening, what works in that context of a country. And the overarching principle is protection and promotion of human rights, gender equality. This is important, that the objective is, and as Jalid has mentioned already, that cervical cancer interventions are part of a broader picture and movement to increase access to care for women and to have parity between sex and gender in access to care. partnership development and integration of the interventions in health systems is of pivotal importance to get the evidence-based intervention decided by the national government into action and to have impact on incidence and mortality in cervical cancer. And nothing works without engagement of effective population, means of women education and men education about what causes cervical cancer and what is preventive to reduce burden of diseases. So without communication through the media to community health, through community health workers, these interventions which we are proposing, immunization, screening, and treatment, will not reach the target population. The overall schematic natural history of disease in a population is this figure. And this figure you might have seen already, but let me go on into detail that every country will put this into practice on its own epidemiological parameters. So it's very important that primary prevention starts when before the first intercourse. So it's important to have vaccine strategies with targets, adolescent girls and later on all boys before sexual debut. So that's a very important and critical moment where you choose strategic steps and where communication starts with the population. The secondary prevention is aimed at detecting pre-cancer lesions, C1, in particular C2 and 3. And this very much depends on the transition probabilities between the stages. We have a window to detect pre-cancer and to reduce incidence by screening. And we have a full session about new and innovations in screening. Screening only works effectively if it's combined with treatment of pre-cancer and referral if there is an invasive cancer detected. So screening is not an isolated intervention, and it's about testing, but it's about integration into a system where referral and follow-up is mandatory. And tertiary prevention, where we have to think about how to manage, this is the bread and butter of ESGO and the gyne-oncologist, how to manage invasive cancer. Unfortunately, stage diagnosis in the African region and other very low-income countries is still high, means 50% of women with invasive cancer are diagnosed in stage 3 to 4, which is, of course, linked with a poor prognosis. So if we put all these interventions together, we can eliminate, but we have to be very attentive that we integrate every single intervention in the overarching framework. We have a political window of opportunity. That's the reason why we are all connected now. We are together in implementing something which is very big, extremely big. We have a regional committee, means all the ministers of health of the African region. And this applies to other regions in the world. But in 2021, the regional committee of the Afro region has decided to implement about a framework of action in the region. And this was taken up by an international and regional effort, which is the African CDC in a roadmap based on very in-depth review of the evidence, what works in the regional context in terms of prevention, early detection, and treatment. A multi-stakeholder partnership has emerged from this Addis Ababa meeting in 2024, and this is very important to take this up and put this into place at the regional and the country level. The status of vaccination very much depends on how effective HPV vaccination coverage is implemented. And so the general principle is that we have a very clear definition of the target age group to implement the vaccine and to choose the vaccine which might be the most, let's say, effective. We know that now, and it's an extremely good news, the single-dose HPV vaccine now is effective as similar to the 3 doses and 2 doses, and and this will be this innovation, the single-dose HPV vaccine, will be very important to effective coverage. The delivery strategy is important according to the opportunities you have in your countries, and the communication, as already mentioned. Monitoring and evaluation of the strategy is important to improve the coverage. Similar key elements are important for screening. The target population of women to be eligible for screening need to be decided at the national level. The test quality is important, and we have many contributions in our session about which tests would be suitable and would be high quality. Quality assurance of these tests and the follow-up is important, and the coverage aim is 70% or 80% according to the population. Now, a recent report from the WHO regional office gives us a picture that although we have a low, still quite work and way to go to coverage of 90%, but I think the good news is that almost in all countries of the African region, there is an ongoing process of national HPV vaccine strategies. And some countries are really big, high performers. 5 countries in sub-Saharan Africa have achieved already 90% coverage. There's, of course, some major barriers still which needs to be overcome. In screening, we have similar problems. There's still in many countries the use of low performance tests like VIA versus HPV, weak access to quality health services. But I think there is and what we as this webinar, we can contribute to increase the capacity and decision making at the country level to develop effective screening strategies per country. We at the Charité are supporting the global picture with some specific projects. We have several hospital partnerships where we dialogue directly with institutions in sub-Saharan Africa. We have created, and my colleague Sarah Nasser is leading a process of virtual tumor conference with increasing participation in sub-Saharan Africa and the Middle East. And we have with Andreas Kaufmann, who is also speaker at this webinar, somebody who is an eminent researcher in implementing new technologies in HPV testing. And he's just coming back from a huge project, a multi-country project in the African countries. My take-home message is, let me see if this moves. It doesn't move anymore. So there's something, yes, take home. And now it's a little bit. What I would like to re-emphasize that we now have this window of opportunities that all the governments are sensitized. The governments in the sub-Saharan Africa, in the Middle East, are sensitized to develop national strategies. And we are all part of that, let's say, global picture. At the national level, you will take responsibility also to advise your authorities about what is the best way to do. And this window of opportunity is for us encouragement to really be part of the picture, to be part of the discussion. Cervical cancer is part of a broader picture of women health, and we in Charité, we have just partnered with UNFPA, the Population Fund, which is focusing on innovation, and I think innovation in cervical cancer is a big driver of progress. Artificial intelligence, telemedicine, which will be dealt with later today, are important tools which can help implement scientifically sound interventions. And we need to work with the private sector. We have to work with NGOs, with champions, to partner as a multi-stakeholder forum in every country, in every region, and we will move forward. And I think we have a lot of possibilities to have success. I would like to thank you very much for your attention, and I hand over to Jalid to move to the next speaker. Thank you very much.
Yes, Andrea, thank you very much, and that you bring even your huge experience into the ESGO, because I think the platform is the key issue, and structure and bidirectional learning sessions. And I'm really proud that you entered the prevention and the ESGO family. And let's move, because there are many lectures, but we have later maybe some space to give one or the other question. And if you have some actions, please write in the chat, and even Andreas always will try to answer. So it's even my personally privilege to announce Mohamed Afifi and to give the WHO perspective. And we are really proud that you identified cervical cancer as the first woman disease at all in the malignant space to bring it in a tipping point. So please give your perspective to the audience.
Thank you very much, Jalid. Good morning, good afternoon, good evening, colleagues, wherever you are. And thanks for this opportunity. Truly appreciate the collaboration and the ESGO's leadership in advancing this very important portfolio, because this is the first time in modern medicine that we have a preventable cancer. And the coming few minutes, first I will start by, the slides are not moving. I'm clicking the slide, but it's not moving.
Just slow.
Yes, moving now. Yes. I will be giving a bit of a glimpse on the incidence and prevalence of cervical cancer, building on Andreas' presentation globally and at the regional and continental level, to see how best we can address this very important issue. The current slide shows in brief the incidence of cancers among women worldwide. And we see that cervical cancer constitutes around 7% of those cancers. And if we move to cancer deaths among women, it constitutes 8%. So it's moving slightly at a higher rate, contributing to women's deaths because of cancers worldwide. But when we move to see the situation in Africa, we see a significant increase in cervical cancer contribution, where it contributes to more than 18% of cancers among women. And if we look at mortalities because of cancer, it's contributing to almost 20% of women's deaths due to cancers in Africa, which is really, we see as shameful because it is a preventable cancer. Now we know it, now we have the technological advances that allow us to contribute to primary prevention and also to secondary and to treating these cases. But primarily on the prevention side, it is largely preventable because of the HPV vaccine and the latest technological developments. But these figures, we see that this almost 20% of women's cancer deaths, it's around 80,000 deaths. Is this figure a large figure or a small figure? 80,000. How can we relate to this? Because the population of Africa is close to 1.5 billion. So someone may say that, okay, so this 80 is a small number, so it should not be a priority. Africa has more pressing health problems. Yes, it's true, but this is a preventable one. And to make sure that it's more relatable to us, the estimation are that every 4 minutes, we have 5 new cervical cancer cases. So in every less than 1 minute, we have a new cervical cancer case worldwide. And we estimate also that in every 2 minutes, a woman loses her life because of cervical cancer. When we move to Africa, we see that in every 4 minutes, we have a new case. So imagine, since we woke up in the morning 2 or 3 or 4 hours ago, how many women in Africa alone have received the information that they have a cervical cancer, and that in every 6 minutes, a woman have lost her life because of cervical cancer in Africa. This situation is grave, and what makes it more complicated and more sad even that it is largely preventable, as we learn. But then what are we trying to do from WHO side? As Andreas highlighted, in 2020, WHO and all member states realizing the crucial importance of addressing cervical cancer and the availability of the tools to prevent this cancer, the global strategy to accelerate elimination of cervical cancer as a public health problem was launched in 2020 with 3 main high-level objectives that we identify as the 90-70-90, where we aim to have 90% of girls vaccinated with HPV vaccine by age of 15, 70% of women screened with a high-performance test 2 times in their lifetime by 35 and 45 years of age. And the last high-level objective is to have 90% of women identified with cervical disease receiving treatment. At the regional level, slides are not moving. Back to the globe. Yeah. Something is not going well with the slide, but anyway, at the regional level, we use the global strategy to develop a regional operational strategy and framework by which we are mobilizing all the ministries of health and counterparts so we can all together join hands and mobilize the support needed to address this problem. What we see now on the screen is a modeling that was done for 78 low and middle income countries for the 3 interventions that are highlighted. In scenario 1 or stream 1, we have the girls only vaccination. Scenario or stream 2, we have the vaccination and once in lifetime screening and treatment. For the third stream, the vaccination and 2 lifetime screening and treatment. And we see from the graph that the modeling shows that there is significant and very fast decline in the incidence and of cervical cancers and consequently the deaths that emanate from this problem if these 3 highlighted streams are implemented in tandem and in timely manner, so we can ensure that we have properly addressed this preventable cancer. The slides are not moving, so I'm waiting for it to respond.
Just click on the screen, please, and yeah, you are controlling it.
Yes. At the regional level, we developed an investment case where we looked at the economic burden of women's cancers in the region, the costing of interventions, and return on investment analysis. We intentionally followed the 3 streams that are recommended in the global strategy, the 90, 70, 90. And the results were in terms of health burden, economic burden, and cost distribution. In terms of health burden, we found that by the year 2050, the estimated number of cervical cancer-related deaths will be more than 500,000 deaths. If we do not make immediate interventions along the 3 recommended streams, we might lose more than 500,000 women because of this preventable cancer. This is the health burden. For the economic burden, it's estimated that if we do not implement these strategies immediately, the 3 streams, as much as we can in all countries, the economic burden would be up to $67 billion. And this is very significant amount of resources that can be otherwise invested in other areas. But what makes it more complicated is that we found that the distribution of the cost follows what you know as the iceberg phenomenon, because governments only see the direct healthcare costs that were estimated to be around 3.4%, whereas the actual costs that the governments do not see, and these are indirect costs in terms of premature deaths, absenteeism, presenteeism, these constitute more than 95% of the costs. So we have here a very important role to play in terms of advocacy and making sure that governments and all counterparts, not only governments, civil society, academia, everybody sees the huge impact of not intervening and the consequences that will be taking place at the community level and at global level, continental level, if we do not make the necessary interventions as soon as possible along the recommended streams. The evidence is telling us that addressing issues vertically, yes, it's good and may help us and show quick results. But if we address it, and specifically when we look at women's health more holistically before, during, and beyond their reproductive years, is a path to sustainable, healthier, and more equitable world. But we know that this is not easy, and it's easier to be more disease-specific or disease-focused. But from a public health perspective, what we are trying to promote is that we have this holistic, broad approach to addressing women's cancers and women's health in general. And this requires an intrasectoral and multi-sectoral approach. So it's not only the role of the healthcare professionals, but it's a broad societal problem that needs a support and the integrated work of everybody in the society. And this graph, the bubble graph that we see online, it shows the distribution of the health problem and some of the determinants of women's health in the Eastern Mediterranean region. We see that women's cancers, the red ball that we see on the left side of the slide, is a huge contributor to the health burden that we have in the region. And it gets more complicated by the humanitarian and emergency situations that we have in the region, which is the second red bubble that we see at the bottom. So this requires a very sensitive and tricky approach that we need to address it in those, they are already low and middle income countries that got more complicated by the ongoing emergencies and humanitarian situation. So it's not about vertical intervention or the disease-specific intervention, but we are promoting and recommending to have this broader approach to address women's cancers and women's health in general, apart from having that disease-focused approach. In summary, the key takeaway messages: we are recommending and working together with all partners to make sure that we have increased investments in introducing and scaling up HPV vaccine to address this preventable cancer. And we need to integrate this in a continuum of care manner. So it should start from the primary care, secondary care, tertiary care, and palliative care in all available platforms, in schools, in universities, in primary health care centers, everywhere. We are promoting a whole society approach to make sure that all partners and all stakeholders in the communities and at the different levels of the society are joining hands to address it. To be able to do this, we need significant investments in data, because we are promoting also evidence-based or evidence-informed interventions. We need to have cancer registries that capture all the detailed information so we can have proper evaluation of the program, identify any bottlenecks, and address them consequently, and to monitor outcomes and use it for advocacy and for mobilizing resources, whether from domestic sources or from international sources. And last but not least is the recommendation to have a comprehensive approach to women's health and to women's cancers, making sure that we do not miss any opportunity, because it's the same woman who's suffering from hypertension, from diabetes, from breast cancer, from cervical cancer. It is the same person who's exposed to all these, at the same time exposed to gender-based violence. So we are promoting this comprehensive approach to address women's health and women's cancers, hoping that we minimize the missed opportunities and maximize the use of limited resources that we have available in our countries. Thank you so much, and this was the key takeaway messages that we are recommending, and look forward to further engagement with ESGO and with all esteemed participants. Thank you so much.
Yeah, so thank you very much for, it's a huge work, and again, it's really sustainable, and we are so happy, Mohamed, that we have with WHO such effective dialogue, and we really hope that even your visions come into the real world. So let's go now to examples and lessons to learn. And I think this is even one challenge, to learn from activities who failed in the past, but even to identify good examples and to bring this in a larger scale. So I think this is something what we want from the ESGO perspective to support. And David Altala, I'm very proud to have you here in this wonderful Congress today. And please share your experience with MEMAGO, a huge network. And it's so wonderful that we have so engaged gynecologists and doctors and other professions to bring better medicine in your and in the global region. Thank you.
Thank you, Jalid. Thank you for this opportunity. It's an honor. Each time you are doing amazing endeavors. Thank you. I'll be speaking, as I was asked to do, about cervical cancer prevention in low-income country and low middle-income countries. And I'll try to share best practice by MEMAGO. And the case of Lebanon, I give an example of the case of Lebanon. You'll understand why. I try to control my side. Okay, this slide is coming from Canada. You can see that the incidence of cervical cancer is 8.3 per 100,000, and their goal is to arrive to less than 4 per 100,000. And beware, this value is exactly as you can see here in Western Asia. So in the part of my world, you can see the incidence that's reported officially. The incidence of cervical cancer is 4 per 100,000 in this part of the world. Moreover, you can see that the prevalence, the HPV prevalence in normal pap smears in our part of the world is 1.7%. But still, by doing studies in Lebanon, you can see that our prevalence of HPV in normal pap smear is exactly in the real world is 4.7%, like in the United States, unlike what is reported in literature about Western country. And this is the part of the world I'm speaking about. And you can see in many countries where you have dark green, the incidence is 0 to 3 per 100,000. That means you don't need to screen, you don't need to prevent. It's a very rare disease here, which is not the case, in fact. In the past, these were the values that were reported, but updating these values with this publication that was done, unfortunately, it was done by Mark Arbin in 2021 in The Lancet. You can see that the incidence of cervical cancer in Lebanon is 5.7. That's real life value. So beware what you are seeing, and you will understand why. Our incidence is 5.7 per 100,000, and you have an increase. You can see the slope of increase on the incidence here in Lebanon in 2018. Don't forget that starting 2019, we had a huge economic crisis, the explosion of Beirut port, the COVID. So afterwards, the data were not reliable. And in 2018, we had 192 cervical cancers in Lebanon. And unfortunately, I don't know why, this was erased from the Ministry of Public Health data on the website, and it was replaced by 88 3 to 4 years later. I don't know why. Still, you see, and then we have inconsistent data coming from here. But what is sure is that we have the highest number, the highest rate, the highest percentage of patients in our region after 75 years old having cervical cancer. So these women were not screened 30 years earlier. So as you can see here in Lebanon, proportionally, comparative to the other countries, we have the higher toll death, the higher crude mortality rate, the higher standardized mortality rate, age standardized, and the cumulative risk at 75 years is higher than other part of this region. And guess what? You can see that these figures, as I said, were deleted, and the population of Lebanon, instead of considering it as 4.5 million, it has been overestimated, including the Syrian refugees. The Syrian refugees that when they are having cervical cancer, they are not reported in the Lebanese registry. And these patients are not treated in Lebanon. They go back to Syria to get treated. So we are diluting the effect of the real data on cervical cancer. And as you can see, the incidence rate that is reported actually for Lebanon is 3.66. That means we cannot have any support for screening. And this is a problem. And this is, I consider this a crime, because we have, by having this incidence of 3.66, which is the dream of Australian government, you don't have any support for your cervical screening. So I get this to reminder, this has been released. We have these figures that are inconsistent. Why I'm saying that? Because we have done a large survey and we have done a large screening on more than 5,000 patients representative of the whole regions with OnClarity test. And we found that HPV was detected in 12% of Lebanese women, 3 to 5 times higher than earlier national estimates, and driven by an atypical dominance of genotypes 56, 59, and 66, and 35, 39, and 68. Moreover, 13.7% of women had abnormal cytology, and yet only 1% showed HSIL, highlighting a distinct low severity, high detection profile driven by non-1618 genotypes in Lebanon. Moreover, the genotypes 56, 59, 66, and 35, 39, 68 dominate across normal ASCUS and LCIL smear, signaling a non-classical low-severity profile that redefines progression risk and calls for genotype-adapted screening and vaccination strategies in Lebanon. Moreover, you can see here that in high-grade cytology, I was speaking about cytology and not biopsy, HPV-16 dominates high-grade lesions, while we have a near absence of HPV-18 and minimal role of 35, 39, 66 that mark a sharp deviation from global norms, highlighting Lebanon's unique oncogenic genotype profiling. Moreover, we have also a limitation of PAP-based screening and reinforcing the global call for HPV-based primary screening, because when you do colposcopy, when you have a normal pap smear and high-risk HPV, you can see that only 33% in colposcopy are normal. Moreover, 1/3 of CIN2 plus lesion had a normal cytology, and ASCUS was equally prevalent in CIN1 and CIN2-3, confirming that the pap smear lacks discriminatory power. and reinforcing the global recommendation to replace cytology with HPV-based screening. Moreover, we have in patients having a negative HPV status before conization, you can see these patients, 18.6% had in patients having conization, they had sometimes somewhere negative HPV. Moreover, in patients having high-grade lesions, you can see CIN2 and CIN3 on colposcopy. You can see that the HPV remained the key driver, HPV 16. And you can see here in the top three, you have HPV 31, HPV 16, and HPV 59, 56, 59 and 66, which is really unusual. And we have underrepresentation of HPV 18 and 45. Moreover, in the follow-up, you can see that after conization, you have in CIN3 lesions having negative margins, only 50% have normal pap smears in the follow-up. And in CIN2 lesions, you can see that 80% had normal pap smears. Moreover, considering the HPV results, you can see that in CIN2 lesions having negative margins at cone, 36% have always HPV positive detection. And in CIN3 lesions after cone, 46% are positive. In Lebanon, we have a low incidence, low prevalence setting, a low incidence of cervical cancer. It's less than 6 per 100,000. Okay, it's 5.7 the real rate, but we need to reduce it more because we are seeing that these figures are increasing. And in the daily practice, we are seeing a lot of patients having positive HPV. So we need to shift, and it's not done yet. We need to shift to primary HPV screening and try to find a solution for the vaccination, as it has been said earlier, to try to vaccinate the whole pediatric population in Lebanon. At least to our target to attain 60% of vaccination of young gender-neutral school kids before age of 13. So in Lebanon, HPV prevalence is higher than expected, and cytology-based triage and screening is clinically obsolete. HPV has to lead. We have non-classical genotypes that dominate the Lebanese HPV landscape, and sometimes some genotypes are partially covered by the vaccine. And the abnormal cytology is common, but poorly predictive of severity. And HPV 16 remains the main driver for CIN2 plus lesion, warranting aggressive management. And post-treatment surveillance cannot rely on cytology alone. It has to be done with HPV genotyping. Thank you.
So thank you very much, David. It's a huge activity, and I think you distillated really the key issues, and we were happy to work with you on this specific items. So thank you very much. Shukran. Zazira.
Shukran, Zazira.
Yes, so let's move to one additional example, and I'm really happy that we condensate all the networks in a global network. And again, it's so wonderful that even we here in Germany or in Europe can learn from you. And I give you some experiences from the PARSCORE perspective. Can I have, please, the slides? And yes, so the PARSCORE was initiated to increase even the awareness for the woman worldwide, not only in the North African and the Middle East region. And I'm really proud that we have now close to 1,000 members, bringing even gynae cancers in a different perspective. So let's move the slides, please. Oh, but It doesn't work, my friend. Can I have the first slide?
Just yeah.
Now it's going. Okay, let's go back. Okay, so only to remind you again that cervical cancer is really a signature disease because we know there's an unpredictable burden of morbidity, but even to influence all aspects of a woman's life. And we know that gynec cancers at all, and I think that if we talk about cervical cancer, we cannot ignore other diseases with woman cancer. We know that endometrial cancer is a huge prevalence and even based on lifestyle, an increasing disease. And we know that if we talk about cervical cancer, we cannot separate only HPV and tobacco, for instance, as a very, very crucial item. And I think what we understood is that empowerment, information, education of patients, of relatives, but even from the medical staff is one of the cornerstone. And that's the reason why we identified even in PARSCO, the Panoramic Research Society of Gynecology, these topics as one of the milestones. If you think that every patient will live longer or every woman and man, that's not true in all regions. And we already heard today that innovation and access is in several regions different. And today we are focused on Africa, but there are many, many structures and underrepresented groups worldwide, even in the so-called Western countries, who have no adequate access to prevention, to early detection, and to treatment. So I love that we have always the global perspective, and that's the reason why even PARSCO want not to be focused on specific countries. It's more the global perspective, and we see that life expectancy, especially for women in specific region, are not such enough what the possibility can give. And that's the reason why if we talk about elimination, we have always to think about a holistic approach about the patient journey. And this is always trans-professional, it's transdisciplinary, and it's even transsectoral. And this is something what in many, many regions missing, the whole patient journey perspective. And this is what we try even to discuss today, how to bring these different parts of the patient journey in a holistic way. So what already Andreas Ullrich also mentioned is that we have the societies, we have the individual centers, we have the academics, and the key issue is that we have to build a structure, and this is not by friendship only, that must be a professional environment. Because what we learned from the past is that we have individual projects funded by regional engagements. But if the program is ending, in generally the network is destroyed. And that's the reason why we have to bring these in a global gynecological task force action. And this is what we do today. And this is something what we have to bring in a better environment, that the cooperations between the societies should not be isolated. It should be synergistic, because every society, every country has at the end of the day limited resources, and it's much better to not make redundant activities. It's much better to make sustainable activity in a synergistic approach. And that's the reason why we defined as one example this call for action. And I'm very proud that the prevention committee and even all protagonists are really able to do it, and they did it, and they will do it even tomorrow. So let's make it really as an alliance. And what you feel, I think, is that the key issue to bring these individual centers and these societies together is the attitude that we have to work together and to be patient and woman centered. And I think this is something what we do. So research is one of the key issue. And we know there are limits in doing phase 1 trials, phase 2 trials, phase 3 trials. But nevertheless, we know that real world data is sometimes much more beneficial than in very highly selected phase 1 study. And that's the reason why we like to motivate you as Africans, but even as global players, to use your clinical routine data to create new evidence. And there are some spaces, this is something what is much easier to do and even much more beneficial, because there are so many patients and we can learn from the clinical routine. And that's the reason why registries and data sharing is one of the key issue. And we just started with the ESGO databases, and I think this can be something what we will adapt to cervical cancer and even to a region with some limitation in their resources. But again, it's so valuable, and please try your best. And this is the reason why we as ESGO pushes as an identity, and that we want to have this commitment for the future. So let's think about global outreach, and this is one part why we even initiated PARSCO, not to be an island, to be in a dialogue with ESGO, with MEMAGO, and even with the other groups, even to share our experience, but even to learn from each other. And I want to show you one option, what we do from the Northeastern German Society of Gynecology, what is one of the co-founder of the ENGOT, European Network for Gynecological Cancer Trials, what is the most successful clinical trial group in the world so far, bringing many new drugs to the women health sector. And we as NOGO are mandated to support Sandist, MEMAGO, the Romanian Society, and PARSCO to support them in doing clinical real-world data studies, but also to start and to empower their individual centers to participate in phase 1, 2, and phase 3 trials. And this is something what I'm really proud that we do this, and even not focusing only on drugs, doing on surgical question, but even to highlight patients' perspective, patients' expectations, and quality of life issues, and to try to qualify even the region. And it's like soccer. So everybody can play soccer, and you need only structures, and you are very good. And that's our dream, that we do really global trials, because so far it's a shame that in general Africa or several other continents are excluded from the new drug development. And this is something what we want to change with this alliance of the different societies. So let's go back to PARSCO. So PARSCO was founded, I think now 8 years ago, and we have several academic interactions, but also we have some projects using digital solutions. And what I really love to highlight is the PARSCO Tumor Conference. For me personally, it's one of the best conferences in the world. Why? Because discussion is very good. It's a global dialogue between pathologists, medical oncologists, gynecologists, radio-oncologists, gynecologists, general practitioners worldwide. And the second is there is a patient advocate in the tumor conference. I don't know any other tumor conference where a patient advocate is sitting there asking specific questions regarding quality of life, discussing about fertility sparing techniques, discussing even the impact of daily life, then in this PARSCO tumor conferences, and showing that, again, even creating new types of conference can bring better empowerment and even a better impact for the treatment decision-making process. We want, as a partner, to bring treatments with our patients into the real decision. And this is something why I really like to invite you that you do this. And I'm really thanks to the specific regions from Egypt, Morocco, and all the other countries who presenting their cases. They prepare even the literature research, and then we discuss it in a very, very respectful manner. So let's use these conferences, especially as an outreach for specific cases, for complex cases, for a second opinion. I think this is something what is a part of elimination. It's not only prevention to avoid any dysplasia or cancer, it's also to bring the best treatment for the patient. And that's the reason why I'm proud that David Chibula initiated this new guideline, what is adapted for limited resources, with the strong impact from you, from the African countries and from the other regions. Because at the end of the day, we are not teacher, we are moderator, and we want to escalate even the guidelines. And we know that we have, again, still underrepresented regions. And we talk about diversity, we talk about access, but it's a shame, again, that we exclude specific regions from the trial. It's not always the infrastructure, sometimes even the target of some pharmaceutical companies, because they are not the target population maybe, but that's wrong. And we will fight for you and together with you that we have to change this. And this is what we did, and was ESGO endorsed, that we have last year the Barcelona meeting, how to overcome that we have still underrepresented groups by ethnicity, by education, by age, by comorbidity. There are many, many elements where we generally exclude specific groups of women from the clinical trial development. And I can promise to you at ESMO and even in ESGO, we are still working now on a code of conduct for trial development and even for presenting diversity in clinical trials. And I'm, again, always against the term of Caucasian. I'm not against Caucasian, but most of the patients are not from Caucasus. And we know this is still in some of the electronic reported formats. And second, that we even not accept that it's only written Europe, North America, and rest of the world. The rest of the world is a core target. And I'm really happy that we are now focusing on pushing even the clinical trial. So this is, I think, the spirit you feel today, and even in our activities, that we really want this topic of equity, and we will work on this. And this is what I can promise to you. This will be one of my main tasks if I start my presidency next year. So this is my part. And now I'm very proud to invite Hisham El Ghazali. Just a few days ago, I met him in Chicago. I was very proud that the Egyptian Society even signed a very, I think, important collaboration with the American Society of Clinical Oncology. And I'm really proud that the colleagues from Egypt are so active on this field, but not only for Egypt, even for the continent. And Hisham, again, I'm very proud that you even think very holistic, and you include even breast cancer and all the gynae cancers, because at the end of the day, we need umbrella structure. Thank you very much for your engagement. Shukran.
Thank you very much, Jalid. It is really, really very impressive presentation, and thank you for the introduction, and thank you for global thinking and introducing and interacting with all the groups and feeling with the sign of equity. And I think this is the main thing that we are working toward, is the equity and also the integration. And I want to thank Zuzana for this very impressive second wave of African cervical cancer elimination virtual meeting, that we have a very successful first wave. And thank you, Murat, and all the prevention committee of the ESGO. And I'm very happy to have the multiple stakeholders here. I'm very, very happy to have the people from Africa, India, China, and all parts of the world. So we have Turkey, I have Italy, so I have London. So I'm very happy. So good morning, good afternoon, good evening for everyone from all over the world. And we are going for cervical cancer elimination in Africa. And as we listen from our colleagues that unfortunately there is increased the cervical cancer mortality in Africa, reaching about 23% of the global mortality. And unfortunately, it will increase to be like 30% of the global mortality by 2030. Unfortunately, also, there is the top 20 countries worldwide of the highest burden of cervical cancer were in Africa. And if you look to the cost, because we are talking also to the politician, that it is important to know that the average cost for cervical cancer management for every patient is almost $50,000. And if you will go for the global, a huge number of patients that may have like 52,000 women will be diagnosed with cervical cancer in the East Africa, and unfortunately, like 70% will die from the disease. Going to this great holistic approach of the WHO strategy to the eliminate cervical cancer, and this 90-70-90 schedule or strategy. So it is very important to look very carefully to this strategy. It is not only vaccination, it is not only screening, but it is vaccination, screening, and treatment, either in the pre-cancer or invasive cancer. So it is, we learned from the achievement that we have in breast cancer, and we achieved in Egypt the 3 KPIs of the Global Breast Cancer Initiative of the decreasing the advanced stage from 70% to only 20%, and to decrease the diagnostic time from 120 days to only 49 days, and also to have multidisciplinary tumor board with the political will for every patients now for breast cancer. And the same, we are starting the presidential initiative for cervical cancer. And because, as David said, that maybe we have low, maybe the incidence of cervical cancer is lower than the Western cancers, and even for Central Africa and Sub-Saharan Africa, it is maybe less than the elimination rate, but the mortality is higher. So it is very important also to personalize the approach of cervical cancer elimination in different countries. And you look here how it is this very, very important diagram. So it is, you know, here that with vaccination, we prevent up to 1 million cervical cancer cases in East Africa by 2040. So 1 million cervical cancer case. If you go for the politician and tell them that 1 million cervical cancer cases, how it will cost if you will not go for treatment and elimination, and the cost of every patient is almost like $50,000. So it is very important, but we have also a very good statement from the CDC Africa that from 28 countries introduced the vaccination, we have successful more than 90% coverage in 5 countries, including Ethiopia and Rwanda and others. So here are the milestone or the roadmap that the CDC want to have or to achieve, like 90% of HPV vaccination in 40 member states, 50% screening coverage in 30 member states, and 60% treatment for precancerous lesions by 2028. And the strategic action focuses securing affordable HPV vaccines and integrating screening into primary care, which is the situation now in Egypt, and which is also very important now that we will listen about the 1 dose or 2 doses, and we have a very good discussion in the IARC about the 1 dose now for the prevention of cervical cancer, and expanding surgical and radiotherapy services and addressing stigma, and which is very, very, very important, especially in the African countries. So the capacity building is something which is very, very important, and we are concentrating on it in the Breast International Cancer Society that I have the honor to be president of this society, and also engagement of every community intervention, multi-sectoral collaboration, and sustainable funding, which is extremely important. Next slide, please. Okay, and here is what we did in between the BGICS and ESGO. Starting from 2019, a lot of alignment between the European Society of Gynecology and the Breast International Cancer Society in Egypt. And you see here this multiple capacity building courses, either in Egypt or outside Egypt, with Jalid, with Nicole Concern, with Murat, and with all other colleagues, that we have a lot of educational activities, especially for the low middle income countries and for Africa. And you see here that in 2022, we started to have the first trial of prevention recommendation that we got for like a consensus meeting to have a recommendation for prevention and screening in 2022. And I think we have the second wave next year, and I will discuss with Murat and Jalid about this. And you see here some of the agreement between the panelists that we have the cytology as the primary screening methods, and deciding different situation, including what we will do in the case of that you have atypical squamous cell with undetermined significance, either to go for HPV testing and colposcopy, and you see the percentage of the experts voting for this, and when to use colposcopy as the standard methodology after assessment and screening. And you see here started the presidential initiative for cervical cancer after the great success of the presidential initiative for breast cancer, and we will go for a lot of discussion about this with Dr. Basel Rifia and Dr. Rida Hamida from Egypt. And this is the methodology that the cervical screening program was done in Egypt, and it is also again will be discussed in details with our colleagues from Egypt. And we started with like a questionnaire to assess the high risk females for human papilloma virus infection, going to pap smear. If it is negative, repeating this after 3 to 5 years, if possible, to go for colposcopy. And here is extremely important issue that we are concentrating on, the colposcopy training courses. So when you start something practical, it is very important to have the gaps. You will know the gaps. So because of that, we have we need the capacity building in colposcopy. So we try to go for multiple activities for colposcopy training courses, and we will discuss this again in 2024 and 2025. And I really want to highlight what achieved in Nigeria, that we have maybe 2 days before, the First Lady seeks synergy against cervical cancer, and they announced that they are reaching almost 89% vaccination coverage, with vaccination of more than 14 million girls, and also screening more than 85 100,000 women. And it is a very good achievement because, as I usually talk to Zainab Shinkavi, that it is important in Africa, the South Africa, Egypt, Algeria, Nigeria, and Kenya, maybe representing the whole Africa. And also, I really was very happy that during the ICC, I heard a very successful Zimbabwe coverage, and also Rwanda, also Ethiopia. So it is. I feel that it is going on, but there is still gaps, including capacity building of the healthcare professionals, and this is the fact that we are working on. We go for a lot of trying for integrating activity, and this is one of our trial to have the maximum usage of the capacity building, also integration, seeing if there is any probability of funding. And this is a meeting between the BGICS, the Egyptian Cancer Society, and also the IARC, WHO, the Awartic, the IAEA. So to go for AFRA project inside African countries, including the radiation therapy facility, including the capacity building, including the training and research activities. In 2025, we go for trying for training, awareness, adaptive guidelines was the main approaches in 2025. And here is what we did with the ESGO during the BGIC on January. A very, very important workshop about cervical cancer prevention, screening, and early detection with Murat and Susanna. And again, roundtable discussion about with Dr. Reda Ahmeda with the African countries. And we will do the same in next January 2026, but will be in person and also hybrid format. So it will be in person and hybrid format. And we will try to go for hands-on workshop in colposcopy in January 2025. We tried to do this with the ESGO support. And this is again with Dr. Sarah Nasser for again virtual conference for elimination of cervical cancer. Not only this, but it is really, we are really proud that we share in the ESGO stratified guidelines for the low middle income countries. So this is the how David Cipolla going for the routine activity or the management of patients of cervical cancer. This is the management, and we are really proud that we are sharing in the what's called the limited accessibility or limited resources stratified guidelines for management of cervical cancer. And it will have, it may go for publication very soon. And I think this is the main, as Dr. Jalid said, the integration, equity, and let us prioritize women health and saving life. And thank you very much for this opportunity. And going back to Jalid.
Yes, thank you very much for your enthusiastic presentation and even your really sustainable work and your leadership. Thank you very much for your engagement. So let's go to St. East, Dilyara Kaidorova. And we are really proud even that we have this cross-national activities, and bring us, please, your experience to the audience, and let's celebrate our interactions.
Hello, dear colleagues. Hello, Jalid, Susanna, Murat, Hisham. Many thanks to ESGO Prevention Committee for organizing this very important virtual meeting for elimination cervical cancer in Africa. Next slide. I can't do with my slide.
Just click, please click on the screen and you will be able to.
Okay, sorry. Cervical cancer is one of the most common cancer in women with detecting more every year, more than 660,000 new cases globally. Oh, sorry. What is it? Oops, sorry. Today I am presented.
Just please be patient. Just give it a few seconds after each slide.
Next slide. Today I am presented Central Asia and East Europe trial group, which includes 18 countries with populations of about 400 million people. And it is one of the regions with high incidence and mortality from cervical cancer. The incidence of cervical cancer varies from 2.5 per 100,000 women in Iran to 20 per 100,000 women in Mongolia. If we look at the countries of Central Asia and the Caucasus, there are more than 4,000 new cases of cervical cancer and more than 2,500 deaths from cervical cancer in this region. In our region, it is limited number of access to screening and vaccinations program, except for Turkey, where the effective screening program and vaccinations have been implemented. Just 4 countries have organized national screening program and HPV vaccination. In October 2024, 47 out of 53 countries have included HPV vaccination in their routine immunization program. 32 countries have implemented a gender-neutral approach to HPV vaccination. And I'm very proud that Kazakhstan now started HPV vaccinations in 2024. And at that time, more than 100,000 girls at age 11, 13 vaccinated. In Kazakhstan, we're using 2 doses of 4-valent vaccinations with Gardasil. Belarus and Tajikistan planned to include HPV vaccinations in the national calendar in 2024. At that slide, you can see that in our countries, in Central Asia countries and Caucasus countries started vaccinations. In each countries all do in school, and we using Gardasil, and we using 2 doses, and only Georgia presented gender-neutral HPV vaccination program with Gardasil 9. Kazakhstan, and one of the first countries among Central Asia, started our organized national screening program 12 years ago. But we can see that we started with cytology, and the results is not good because mortality is stable, and the new incidents are increasing in our country. And now we presented for our government new screening program for using HPV-based screening. And most of presented countries used cytology screening program. But Uzbekistan started pilot on HPV-based screening program. And based on the burden of cervical cancer in our regions, and in order to conduct clinical trials in the gynecology cancer field, we created new research network. And during the period, this 4 years period of our cooperation, scientists have done a lot of work on the study of gynecology cancer. And scientists is a team of like-minded people. We have enough strength to continue our fruitful work. Of course, we have a good relations with ESGO, and we are ready to work and to collaborate from our regions with ESGO and another societies to eliminate cervical cancer. Thank you, and we are always open to collaboration.
Yes, thank you very much for this outstanding network and even your activities. And it's so many women will really benefit from your events and your sessions. So thank you very much. And now we have the final presentation of the first chapter today. And it's really my big pleasure to invite Mark Arbin. We always know he is a living legend. And thank you even for your work in ESGO Prevention Committee and your outstanding papers regarding HPV prevalence and activities to reduce the incidence of cervical cancer. So Mark, please, for us is yours.
Thank you very much, Jalid, for this nice introduction. Also, thanks for the organizer that I could move a bit to an earlier presentation because I have to run after my presentation to the airport. I will talk about the screening methods, and the major screening methods are visual inspection after application of acetic acid, cervical cytology, high-risk HPV testing, and I should try to answer which is the best option for African countries. Waiting for my next slide.
Just click in the presentation. Yes. No.
Yeah. So I will talk about the different policies that which are currently ongoing in different African countries. We will then discuss the efficacy, effectiveness of the different screening methods. We will compare HPV with cytology, HPV with visual inspection, also HPV with co-testing. Then we will make the conclusions of different meta-analysis and try to answer the question, which is my task, what the best screening methods could be for Africa. And I will stop with discussing some challenges for the continent of Africa. Now, we have now finalized a world survey on cervical cancer screening. It was the second cycle, including last year and this year. And we had answers. This is the situation in March 25. You see that almost all countries are in green. There are a few countries lacking in Africa, a few islands in the Caribbean, which you do not see. For the rest, all countries responded. And in the meanwhile, Chad, South Sudan, Uganda, Malawi have already contributed. From Eritrea, we did not have any information. So for the moment, we still need updated information for the Central African Republic, for Sao Tome and Sierra Leone. So if there are people from these countries listening, please contact us. From Eritrea, we did not receive any response, also for the period of 2023. Now, what is the situation in the world first, and then I will move to Africa. Regarding the introduction of HPV-based screening, we see that in dark green, there are 23 countries with organized HPV-based screening. They are mostly localized in Oceania, with Australia and New Zealand, several countries in Western and Northern Europe, Turkey, and the others are in phases of introduction of HPV-based screening. 38, the rollout is ongoing. In 41, there are organized pilots. In 27, like for instance, the US, there is HPV screening, but it's only opportunistic. 43 countries have planned HPV screening, and there are 40 where there is no HPV-based screening. But let's look now at Africa. Here we see that there is one country with organized rollout of HPV screening, and you do not see it. It is the island of La Réunion. There are 9 countries where organized rollout is ongoing, at least in some regions of the country, and they are in light green. 13 countries have pilot projects, and the rest has opportunistic HPV testing, or it is planned, or there is no HPV testing at all. Here you see, I have only the world map, where each test is frequently used. We see that visual inspection is essentially used in Africa, whereas cytology and HPV is more widespread at world level, and there are a few countries where co-testing is the recommended screening method. Now let's look what the performance is of all these methods, and we will always compare with HPV. So first, cytology versus HPV screening. Here we have a forest plot, and we have included 8 randomized trials. We have included the last trials conducted in China. We see here the detection rate ratio of SIN3 plus lesions among women that were negative in the HPV arm versus the detection of SIN3 plus among women that were cytology negative in the other arm. And we see that this quotient, this ratio, in all the trials was lower than unity. And when we pool all the trials, the pooled relative risk is 0.44. This means that HPV negative women have an incidence of CN3 plus, which is 56% lower than women with a negative cytology in the first screening round. If we look at the outcome, advanced cancer, which was defined in some trials at 1B plus and in the last Indian trial as cancer of stage 2 plus, we see overall a reduction. If we pool the 5 trials, we come to 0.63, which means 37% lower cancer incidence among HPV negative compared to cytology negative. Now let's compare visual inspection with HPV. In fact, there is only one randomized trial that compared these 2 screening tests. This was the Osmanabad trial, published by Sankar in the New England Journal of Medicine more than 10 years ago. And we have here the cumulative incidence of stage 2 cancer or higher. And at right, we have the cumulative mortality. In orange, we see the cumulative incidence among women who were screened with HPV. And in the other colors, we have the incidence among women in the control group, where there was no screening, or there was screening with VIA or with cytology. And we see that there is a substantially lower cumulative incidence of stage 2 plus cancer and also of the mortality from cancer. If we summarize this, it was not in the paper, but we could compute it ourselves. The relative incidence of cervical cancer in the women screened with HPV versus VIA was of the order of 0.81. This was not significant, but if we look at the incidence of advanced cancer, we have a ratio of 0.55, and the mortality was in the HPV screening group. The relative risk was 0.60 compared with the VIA screening group. Now, co-testing. Co-testing means you apply two screening tests, and cytology and HPV, and you compare with HPV alone. Here we have summarized this comparison in forest plots again. Here we have the detection rate in the first screening round. And we see that if women are screened with two tests, the detection rate will be just 6% higher, and this is not statistically significantly different from UNITY. If we look at detection of SIN3+, the pooled relative risk is 1.03, again, no statistical significance. If we look at from a longitudinal perspective, we can look for screened cohorts or randomized trials. We have here European cohorts with different countries contributing, and we have in blue the cumulative incidence among women who were cytology negative. In red, those who were HPV negative, and in green, those who were co-test negative. And we see a remarkable higher incidence in the women screened with cytology and were negative with cytology compared to those who were negative for HPV or co-testing. And we see this pattern also in the Dutch randomized trial, in the Swedish randomized trial, and also in observational data from the US. Everywhere you see a remarkably higher incidence of the negative cytology compared to women who are HPV negative, and the difference between those who are just HPV negative and co-test negative is very small, and in fact the difference existed already from the beginning. We see that these two curves are quite parallel and do not increase over time, indicating the very low contribution of co-testing compared to HPV testing alone. So we can conclude that HPV testing is more effective in reducing the burden of SIN3+ and also of cervical cancer compared to VIA and cytology. VIA is cheap, it is largely available, but subjective, and the performance, we see that in the forest plot, is extremely heterogeneous. Cytology is not so widely available. If we look at an African continent, it requires trained resources, is also subjective, and the performance is heterogeneous. However, HPV testing is more sensitive, objective, reproducible, can be performed on self-samples. HPV detection can also be limited to the 8 most carcinogenic HPV types. And WHO consider these more simple and also cheaper tests as acceptable. Now, what are the challenges? We need an affordable, robust, validated HPV test that can be performed on a clinician sample and also on self-samples. We need validated point-of-care tests, and we need also simple management algorithms. And for Africa, we note 2 major options: the screen and treat, or the point-of-care screen, point-of-care triage and treatment. For triage options in this latter strategy, we note the possibility to look at the genotyping detail, when the tests have limited genotyping capacity, or we can fine-tune more if we have an extended genotyping test. Also, artificial supported portable colposcopy devices and VIA still is an acceptable triage option. The new paradigm for the future, and in particular for Africa, is HPV vaccination of young teenager girls, and once or twice in a lifetime, screening with validated HPV tests in the age range 30 to 45 years. Dear colleagues, I thank you very much for your attention.
Yes, Mark. So thank you very much for this wonderful presentation. And so we wish you a safe trip wherever you have to fly and to fight for better diagnostic and better treatment approaches for cervical cancer. Thank you, Mark.
Maybe I can just say one
Please.
additional thing. So we had a marvelous experience with a huge response rate in our cervical cancer screening survey. We have received information from many African experts, and I'm ready to share our experience and our address list so that ESGO can use this and we can collaborate together on this. Thank you very much for giving me the opportunity to discuss with us. And now I have to leave. Thank
Yes.
you, Jalid.
So safe trip, Mark.